So may I start, Amy?
Yeah, yes. I guess so, because there are more than 300 participants. Maybe I can introduce you, Nicolas. I think the lung function lab is really a core facility for us as pediatric pulmonologists, and I'm really very happy that you are going to give a lot of details about static and dynamic lung volumes. Nicolas is a professor in pediatric pulmonology in Lucerne in Switzerland, and our second speaker is Monica Gappa, and she will talk about bronchial provocations tests and bronchodilator reversibility. And we just decided to take all the questions at the end of the two presentations. So please, Nicolas.
Good. Just as I just saw that Monica wrote that she has problems logging in, so maybe Amy needs to help her. Okay, so I start hello everyone, talking about lung function. In this topic, I have no conflicts of interest. Let's see if I can move the cursor. I cannot. Yes, okay. And I hope to show you a little bit the differences of spirometry and bodyplethysmography in this talk. We'll start with the easy one, with the spirometry, and then we go to the little bit complicated one, the bodyplethysmography. So I just start with a question that you can try to answer with a poll. It should be an easy one, just to see what's the background of the participants. I hope everyone can do this correctly. So can you start a poll? Yes. So I hope I can continue. So can I just, yes, okay. So 9% of the people have answered correctly. The residual volume is the thing you cannot see on the flow volume curve or the flow time curve in spirometry. And so that's why we start with these dynamic lung volumes, the ones that you have to breathe really forcibly when you do the spirometry maneuver. So the spirometry is the test, lung function test that everyone knows very well. You can do this with very small apparatus or a little bit bigger ones. It's feasible for children about 4 to 5 years old. And the important thing doing spirometry is really that you need to do a very, very strong effort, quick effort. And you need to have a good trained technical support to motivate the child to do this strong effort. So we always see you need to hear in the next room your technician saying like shush, so that really the child does this forced breath expiration while doing the spirometry. While the spirometry, you can measure volumes and flows, and you show then the volume time and the flow volume curve. So the volume time curve, the first one, is the one that's depicted here. And I guess you all know where you start. So you start with a full inspiration. So you're at the total lung capacity, and you expire your complete air until you are at the residual volume. And in 1 second, the volume that you've expired in 1 second is the forced expiratory volume in 1 second that you can read from this curve. The other curve that you obtained from the spirometry is the flow volume curve. So this is the one curve you will see the most often when you do lung functions. And you have here these forced flows. Here the inspiration and the expiration. So you start like before at the total lung capacity, and you breathe down to the residual volume. The air that you've expired here, the volume, is the forced vital capacity. And here on this axis, you will see the flows. So you have the peak expiratory flow, the maximal flow that you have, and then also the maximal flow when still 75% of your volume is in the lung, or here the half of the volume is in your lungs, or here the flow where 25% of the volume is still in your lungs. So the MF50, you take here the half of your volume, you put a line, and you see here the maximal flow. In the US, they used a little bit of different nomenclature. They say the forced expiratory flow here when 25% of the air has been expired, 50% or 75%. So when you combine these two flow and curves that we have seen now, you can have all these volumes and flows that can be seen. An index that's used quite often is the TFNO index, which is a good index for indication of an obstruction of the airway. You can also look at the mean values or the mid values of your flows at the 75, 15, 25%, and you have these maximal mid, sorry, not mean, mid expiratory flows. So there are some criteria that you need to fulfill to have good lung function testing with spirometry, and these you will find them in this document. It's quite a 15-year-old document of in the ERJ, where you see which are the minimal acceptable criteria to have a good spirometry curve. So you need for children to expire at least 6 seconds. You need to have 3 attempts that are free from artifacts, and you will take the best values of your, the best curve of your 3 curves, and you have to have curves that are quite reproducible, so that you can do 2 or 3 times and they show the same values. There are normative values for the lung function testing and spirometry, and we will go to this a little bit more in detail in the workshops. But important is to know that the lung function values, of course, they will depend on the age. A 6-year-old child will not have a flow as high as a 10-year-old. And your values will depend on the ethnicity. So if you're Caucasian white, or if you're black, or if you're Asian, of the age, of the sex, and the height. Important to know the weight is not important in giving you a normative value. So when you look at the flow volume curve, there are 3 things that are important to look at. Don't go and look there directly at the numbers, but first look if really the 3 curves have been done correctly, and then look at the shape of the curve and different things on the curve. So you first look, you should have a really sharp increase of your flow at the beginning of the expiration. So this is the expiration, you have the inspiration. And then you have a sharp peak at the top. So this lung function here is not very, very nicely done. You should have a linear curve that can be concave shape. That doesn't play a role if it's done well or not, but it has not to have any waves here inside. And then you can also have a look at the inspiratory loop. And then finally, you will look at the numbers. We have 2 main patterns that you will see in spirometry. The one is the obstructive pattern, where you have this concave shaped form of the expiratory flow. And this is a typical pattern that you will see, for instance, in asthma or in CF. And if you look at this, at the numbers, then the numbers that are the mostly diminished are the flows, especially when you go at the end of the expiration. So the MF 50 or 25. Or these mid-expiratory flows. If you have a severe obstruction, you will then also have diminished FEV1. This is the TFNO quotient that will be reduced, and only in cases where you have a very big obstruction with also hyperinflation, then you will have diminished volumes that you can mobilize, the diminished FVC, or also peak flow that will be diminished. In asthma, you typically have a reversible obstruction. So if you give a bronchodilator, this typically concave shaped curve will get straight again with normal values again. The norm values for adults are usually the FEV1 that has to increase of 12% or 200 milliliters. This is not really applicable to children where you don't have this large increase. There is one paper that looked and said maybe 8% increase in the CAMP study. This was done, would be a good cutoff, but it's more to look at the curve if really you have this difference that will indicate you the bronchodilation. The other big pattern is the restrictive pattern. For instance, the one you will see in a lung hyperplasia or in a neuromuscular patient, where the main thing is you don't have a curve that is concave shape, that has normal shape, but the main thing that you will observe is the FVC, so the volume that is reduced. If you have a severe obstruction, of course, you will also have diminished peak flow, FEV1 values, or also the small values, but the quotient FEV1 to FVC, so the TFNO quotient usually will stay normal. So this is not a poll really to take, it's just so that you think a little bit with me of these two large patterns that you have. In asthma, you will have an obstructive, as said, pattern. In CF also an obstruction. In lung hyperplasia, this would be restrictive. Pectus excavactum, also restriction. Pneumothorax, the same. You have basically small volumes that you can mobilize. Vocal cord dysfunction is also an obstruction of your large airways. You might see, especially in the inspiratory flow, an obstruction. In neuromuscular disease, it's also a restrictive pattern. Tracheomalacia, which is an obstruction of your airways, which show you reduced flows. Lobectomy is a restrictive pattern. And bronchopulmonary dysplasia might be both obstructive and restrictive. So I talked about these two typical flow volume loop patterns, the obstruction, see in asthma, the restrictions. There are other ones that you can see, maybe in CF, in pediatrics a little bit less often, but the emphysema, ones where you have a very good peak flow and then a collapse of your airways, which makes that you have like this, this really sharp decline also of the flow here. If you have a variable intrathoracic obstruction, like this morning Ernst Eber has shown, where you have, for instance, a tracheomalacia, you might have a good flow just at the beginning, but at the moment the large airways collapse, then you have an obstruction in the airflow. If you have the variable extrathoracic obstruction, which would be the case typically of a vocal cord dysfunction, then you will have this restriction, diminution of the airflows during the inspiratory curve. And if you have a fixed obstruction of your airways, let's say in a pulmonary vascular sling or any malformation that gives you a fixed obstruction of the trachea, then you have this decapitated flow volume curve as well in expiration as also in inspiration. So this would be some case of bad technique or something that is you don't like looking at your curve, especially if the curves look differently. In the first one, you would have the child doing these big waves here. This would be typical for coughing. This is a thing you need to think about when you have kind of this shape of the curve, that you can have the child biting on the mouthpiece during the expiration, and then you have suddenly this drop of the airflow. Or here in a case like this, the child also putting the tongue in the mouthpiece, which gives you also a block to the expiratory flow and an obstruction. So spirometry is used to diagnose, monitor, to look at the prognosis of many lung diseases. It's the most commonly used test. I think one important indication is also to objective, to have an objective measurement of what's happening in the airways. For instance, if you have an asthmatic, a poor perceiver, that you can have an objective measurement of really these airways are open or closed. Okay, so that was, I would say, the easy part of the talk. So we go now to the static lung volumes. The static lung volumes, I start also with a multiple choice question, which is probably a little bit a more difficult one. You can have the poll, please. So which of these statements is correct? Okay, we'll see the answers.
And we might have to give them a few more seconds.
Okay, sorry. You have seen already the
That's
answer.
okay.
So
they vote very, very quickly, but they might need just a few more seconds.
Sure.
Thanks.
So is it okay? So I show the question. Okay, so, this is correct, but not only everyone has voted correctly. So I just go very quickly to tell you what are the correct influenza ones. So the FRC measurements are based not on Hagen-Poiseuille's law, that's a law of the vessels and diameters of the vessels, but it's Boyle's law. The measurement of total lung capacity is an indirect measure, I will show you. SRF is not more sensitive to resistance change than SRTOT, it's the contrary. I will show you this on the curve, and this is the correct answer. And here SRO is determined by plotting the flows at the mouth during versus the respiratory efforts. So the 4 was the correct answer. So bodyplethysmography is also feasible from preschool age, but here you do a slow breathing. And the principle behind flow bodyplethysmography is that you look at the compressibility of thoracic gas volume. And important to know also is that you will see volumes that include the non-ventilated volumes also, not only the ventilated volumes in your lung. You will have as a primary measure the intrathoracic gas volume, which is called also functional residual capacity measured with a plethysmograph. And you will have these values calculated. So Boyle's law tells you that when you compress a gas, you diminish the volume of a gas in a closed container, you will increase the pressure of this gas. And like changing volumes and assessing volume changes and pressure changes will give you, show you volumes of your lung. And how is this done? This is done during this measurement of the FRC curve. The FRC curve, basically what the child does is it breathes against a shutter. So against a complete resistance where no air goes through, and the child makes any frustrating movements of the thorax, no air passing. And here you have on this axis, you have the movements of the thorax, the efforts of the breathing. And here on this axis, you will have the pressure of the mouth. And what I explain to the students is always, if you have a small balloon and you do quite of an effort of movements, then you have big changes of pressure in this balloon. But if you have a large balloon and you do the same efforts here, you have small changes of pressure in the balloon. So if here you have on this axis the movements of your thorax, your work of breathing, and here pressure, if you have a large increase of pressure, therefore a very steep curve, then this is the small balloon. If you have a flat curve, then this is the large balloon. So large balloon, large lungs, large FRC, functional residual capacity. That's a place where you breathe when you breathe slowly. And that's the first measurement that you obtain in the body. It's the FRC. From this one, then you combine some slow measurements where you can measure volumes. And then you have here these different volumes that you can measure: inspiratory, expiratory reserve volume, or the tidal volume. And you can also calculate the residual volume by subtracting expiratory reserve volume from the FRC. The other thing that you will be able to calculate are capacities, which are sums of the volumes. If you add this volume and this volume, you will get the inspiratory capacity. If you add also the 3 volumes here, you will have the vital capacity. Or if you add the residual volume that you've calculated before, then you have the total lung capacity. What is important to know, and I think this is one of the messages I would like to pass through when you look at your lung functions, is to know what setting you have during your maneuvers. If you have a body where you have an inspiratory effort first and an expiratory, the volumes will be calculated like this. You have the forces and the functional residual capacity first calculated with your body, and then you have an inspiratory maneuver. I take full air, and so I can calculate the total lung capacity. And then from this here, I have a full expiratory maneuver, and you can then calculate the residual volume. So the residual volume is calculated by 2 equations, one after the other. If you have the other setting of your body where you first have an expiration and then large expiration, the first measurement will be FRC minus the expiratory residual volume. That gives you the residual volume. And the second one is the total lung capacity that's calculated by adding the vital capacity inspiratory. The FRC, the residual volume, the volume in your lungs, can be also calculated by other means than by the bodyplethysmography, by gas dilution techniques. And Monica will, Gappa will in the talk in about an hour, talk more about the gas dilution techniques, but I show you just the principle behind it. If you have 2 containers and you know the volume of one, here, this one, where you have a concentration of a gas, and you would like to know the volume of the other one, which is the lung volume, you would like to know where you breathe slowly, then you do a complete breathing, breathing until you get an equilibrium of these two gases. And by then, with this formula, you can then calculate what's the concentration. When you know the concentration in your the final concentration of your gas, you can calculate the volume of your lung, basically of your first container, which is important to know when you do FRC measurements with the gas dilution, that it only includes ventilated area, because these are one where you will have the equilibrium of the gas. So the FRC that you've measured with the gas dilution is always smaller than the FRC that you've measured with the body, which includes all the gas that you have in your thorax, maybe also in your abdomen, which has been compressed with the maneuvers. And the difference, subtraction of the volume that you've measured with the body, less the volume measured by the gas dilution techniques, is what we call the trap air. So that's air that does not participate in gas exchange. So the next thing you can measure in your body plethysmogram is the airway resistance. And that's quite easy to do, because there the child has just to breathe slowly with the shutter that's open. So normally, normal breathing, slow breathing. And here you measure with a pneumotachograph, you measure the airflow that just comes out in and out. And here you have again in this curve here, or in this axis here, you have the efforts of the thorax, so the movements of your thorax, which are measured indirectly by changes of pressure in the box. And here on this axis, you have the flow that goes through the pneumotachograph. So if you have opened airway, large airways, then there will be a lot of air going through with the same effort. So your curve here will be a very steep curve. If the airways are very narrow, for the same effort, well, you will have not much flow going through, so your curve will be very flat. You can measure in different way the steepness of this curve. The specific airway resistance, how we call it, can be, you can measure what we call the total specific resistance. Here you take the highest point here and the lowest point here, and you draw your line. Or you can use what is most people do is the effective specific airway resistance, which is like an integral of this whole curve, or just a mean value of this whole curve. The total specific resistance is more sensitive, because if you have let's say you give Ventoline and you have an opening, this curve will get much flatter, you can imagine, much steeper, sorry, you can imagine, than this one, who will move less. But this curve here is more reproducible if you do several efforts. So this is the one we mainly use. There are different loops of the airway resistance. This is the classical normal one. If it gets very flat, then you have an increased resistance of your airway. And one that you might see, especially in advanced obstructive disease, is this golf club shape. What happens here you always have the inspiration, and here you have the expiration. And the moment you are at the end of the expiration, you have a sharp increase of your resistance and therefore less flow, which is explained by the moment your airway collapse during the expiration, because your expiration equilibrium point has reached the point where the airway is collapsed. This curve here, honestly, I do not know exactly how this comes with the elevation of the diaphragm. And this one is easily explained also. If you have an extrathoracic stenosis, the moment you do the full inspiration, suddenly you don't have more flow that goes through, or the same during the expiration. So that's how the whole will look in your lung function test here. You will have these different resistance loops that are measured every time the child breathes slowly with the steepness of the curve. And here you have these FRC loops that looks like this. Here you see also exactly the mathematical way to calculate the volumes or the resistance from the steepness of the curve. And here you have a link to see how the whole process of lung function, including spirometry and body plethysmography, is performed by a child. It's very well explained if you want to look at this or show this to your students. So indications, indications to do this. I've lost my thing here, sorry. to do the body plethysmogram is also to have additional volumes that you cannot have in the flow volume curve. For instance, the residual volume, the total lung capacity. This is very important, for instance, in assessing restrictive lung diseases. So I have to just stop my iPhone because it blocks my computer. Okay, hope it works. So I'm back. And finally, if you have understood all this, then you can see how these curves, the interplay of these curves. You have a slow breathing that the child does here at the volume at your FRC plate. Then you have the maneuver of occlusion of the shutter, where you calculate then here your lung volume. Well, no, that's basically how it's first taken, the height. And then you have your forced expiratory slow maneuver of expiratory and inspiratory maneuver, where you can have all these volumes and capacity calculated. And then the child does this quick, fast expiration, the spirometry maneuver, where you can have the FEV1, the volume in 1 second. And you see here, like turned around the axis where you have now the flows, and you see from the total lung capacity to the residual volume, how the flows increase and go down again. So if you understand how this works, then you have understood the whole principle of spirometry and body plethysmography. So I will end my talk here, and I hope this was not too confusing, and thank you for your attention.
So thank you very much, Nicolas. Can you hear me?
I hear you well, yes.
Yes. So as soon as my presentation is loaded up, I will directly follow up from Nicolas' talk. And
Okay, a second, we're just changing it over to you now.
Yes.
At the moment.
Okay. So how do I advance this? I use my...
You click once with your mouse.
Yeah, I did that. Okay, no conflict of interest. And I'm directly following up from the baseline measurement of lung function using spirometry and body plethysmography. And the content of my talk will be more details about how to assess the bronchodilator response and how to perform a bronchial challenge test. So before I start, I want to make a brief historical excursus because I think there's one name you need to know in the context of lung function testing and especially bronchial challenge testing, and that is the name of Robert Thévenot. He was a French pharmacologist and physician in a tradition following from his father, who had the same profession and also an interest in respiratory physiology already. Robert Thévenot was the first one to really describe expiratory flow rates. He was always working in a team, but he invented the FEV1, which was also called Thévenot's test, and the FEV1-FBC ratio, the Thévenot's index you've heard about already today, which really is the index to describe obstructive or the severity of obstructive changes in different diseases. With regard to the bronchodilator test, he was the first to use beta agonist isoproterenol to assess bronchodilation, and he was also the first to do pharmacological bronchial challenge testing using acetylcholine. He defined PD20, I will talk about later, but unfortunately his life was rather short. At the age of 50, he died of a heart attack in front of his hospital. So he was a very important person for respiratory physiology and lung function testing. With regard to bronchodilator response, the first question we need to answer is how to assess bronchodilator response. On the left, you see a flow volume curve, which you should recognize by now. Two flow volume curves, actually the blue one being the baseline measurement, and the second, the red one, being the forced expiratory flow volume curve after bronchodilation in a child 12 years old with allergic asthma. Now, standards how to do bronchodilator testing are in the same ATS-ERS document that Nicolas has already mentioned, published already in 2005. You do a baseline measurement of FEV1, then you do inhalation of a bronchodilator, usually with the salbutamol MDI, 2 puffs in children less than 6 years old and 4 puffs in all older subjects. And the recommendation, at least in children, is to do the inhalation via a spacer with a mouthpiece. And then you wait 10 to 15 minutes and repeat the same measurement. And a significant response is defined as an increase in FEV1 of greater than 12% or 200 mils absolute volume compared to the baseline measurement. But you've heard already that these recommendations do not really apply to children. We have a very high variability of the bronchodilator response, and the cutoff that is set in guidelines is really arbitrary. And Nicolas mentioned already the CAMP study, which tested or had a large number of children with asthma in the lung function lab. And they found that the cutoff that is recommended in the guidelines of 12% has a sensitivity of only 36%. Now, sensitivity, just to remind you, is the number of subjects who are correctly tested positive. And specificity, on the other hand, are the correct negative answers. And what they also find that they looked at different cutoffs. Here is the 12%, sensitivity of 36%, high specificity, but you won't detect all the children with asthma. And the best cutoff here in the CAMP study, children with asthma, was a cutoff of 8%, so much lower, and that gives you a sensitivity of only 54% with a specificity of 77%. So it still misses 45% of the children with asthma. However, if you take into account your baseline lung function, then you may end up with a better discrimination, a better sensitivity. If you have children with a low lung function at baseline, less than FEV1 80% predicted, your sensitivity and specificity is much better compared to children with normal lung function at baseline, where you will always have a very low sensitivity and specificity. Now, why do we want to assess bronchodilator response? It is part of the diagnosis of asthma, for example, in the GINA guidelines. It gives you or it is associated with asthma control. Actually, I have to sort of, yeah, now it's better. It's associated with asthma control. If you have a bronchodilator response in a child of more than 10%, this is significantly associated with poor asthma control, and it also is associated with prognosis. Children with a persistent positive bronchodilator response are at risk to lose lung function over time. This is also data from the CAMP study. Spirometry is not the only lung function technique that can be used to assess the bronchodilator response. There are a number of other techniques which are not specifically covered here. You've heard about measurements of specific airway resistance. If you use these techniques, you have to remember that they have a different variability compared to the FEV1. And then you have to use a different cutoff to define a significant response. So your choice depends on the method, or the interpretation depends on the method, and the choice of the method depends on the patient. Just a few key points for the bronchodilator response. Bronchodilator response is used to demonstrate reversibility of airflow obstruction. It is a key feature of asthma, and if you have bronchodilator response, it supports the diagnosis of asthma. Official recommendations set a cutoff at 12% or 200 mL, and you assess this response after inhalation of 4 puffs of salbutamol. But in children, the sensitivity and specificity of these guideline recommendations are very low, and it depends on baseline lung function. It is better if you have a low baseline lung function, and you have to remember this when you interpret. It is one piece of the puzzle, and you need to use other markers for the diagnosis of asthma, and we will hear about that later. I've told you persistent bronchodilator response associated with worse prognosis and loss of lung function over time. Oops. My mouse is not working now. Yes. Okay. The contrary to the bronchodilator response is the bronchial challenge testing to assess bronchial hyperresponsiveness. There are a number of potential stimuli, and they can be divided into direct versus indirect challenges and natural versus diagnostic or iatrogenic challenges. And the direct stimuli include histamine challenge and methacholine challenge, which is the challenge most commonly used. They are sensitive but not very specific. And indirect stimuli, and I will talk about the standardized exercise challenge, are less sensitive but more specific for a diagnosis of asthma. You have to remember that bronchial challenge can induce a positive response in every person. Here you have healthy persons who have different degree of bronchial responsiveness, and there is an overlap with bronchial responsiveness or bronchial hyperresponsiveness in different diseases. With increasing doses of methacholine, you will elicit a bronchial response in every subject. And this overlap has to be taken into account. When do you use a bronchial challenge test, or which bronchial challenge test do you use? And here is an example. A 15-year-old adolescent who already had several episodes of airway obstruction requiring hospital admission, but with a completely normal lung function. Here you have the spirometry curve, an FEV1 of 120% predicted and no interval symptoms. So what do? You want to know whether this boy really has asthma. The best bronchial challenge test would be to put him on a treadmill and perform a submaximal exercise challenge. Now, how do you do this? You want him to exercise to reach 50 to 70% of his maximal minute ventilation, or 80 to 90% of the maximal heart rate. And to do that, you let him run for 6 to 8 minutes with a protocol where you increase the speed and the steepness of the treadmill for 1 to 2 minutes, and then maintain this speed and steepness for the remaining time. You should have a stable environment, and standard settings for the average child is a speed of 5 to 7 kilometers per hour with a slope of 10%. And you consider the response to treadmill exercise positive if the FEV1 drops by 10% or more. You do a baseline spirometry and repeat spirometry 5 to 10 minutes after the exercise. And if you see a positive response, this of course will be followed by a bronchodilator test. What happens in exercise? It's voluntary hyperpnea, and this leads to respiratory water loss in the mucosa, mucosal dehydration, and this is the bronchial stimulus that will lead to bronchoconstriction. Here you have the response in this case, the spirometry curve, where you see a marked drop after the bronchial challenge, the treadmill challenge, and the same here in the plethysmography. If you, in numbers, there is a drop in FEV1 of 83%, and this positive indirect bronchial challenge confirms bronchial hyperresponsiveness in this boy and supports the diagnosis of asthma. However, I told you the sensitivity is low and it may not work in all patients with asthma. So if the exercise test is negative, you have to choose a different bronchial challenge test. And this means you, most of the times you go on to a direct challenge and most of the time methacholine. How is a methacholine challenge performed? You can either use this Cockcroft method where you have different concentrations of methacholine that are nebulized in these bags. But the more modern, more easier method is using a dosimeter system where you have a single methacholine concentration, and by inhaling in different steps, you increase the doses, cumulative doses, in a similar protocol, doing a baseline spirometry and perhaps resistance measurement, and then repeat the measurement after each of these steps. And what you report is the provocative dose that leads to a drop in FEV1 of 20%. In a protocol, this will look like this. Here you have on the right-hand side upper panel, you have the methacholine protocol, baseline measurement, first step of provocation, second step of provocation, and then the bronchodilator test afterwards. The blue line represents FEV1 in percent predicted, 100% at baseline, drop at the second inhalation, and then recovery after bronchodilation. And here is the corresponding change in airway resistance. Here you have the flow volume curve, which directly gives you the same information. And there's a clear positive bronchial challenge after the second dose with a significant fall in FEV1 with the PD20 calculated at 0.1 milligram, and that is equivalent to moderate bronchial hyperresponsiveness consistent with a diagnosis of asthma in this patient. These are just two examples how to perform a bronchial challenge test. There are a number of other triggers which can be used, and you will find recommendations for further reading in the written summary you got, and in the more extended version of this talk. But one thing that I find very important is an allergen challenge should not be performed in children. This is not part of pediatric respiratory medicine, just the non-specific challenges. So just a short summary of the bronchial provocation challenge. I think my time is over. Bronchial hyperreactivity is a hallmark of asthma, but is also present in many other respiratory diseases, and there is an overlap with healthy subjects. So similar to the bronchodilator test, it's only a piece of the puzzle and has to be interpreted with other clinical and physiological markers. A bronchial challenge test allows you to assess the degree of bronchial hyperreactivity. In asthma, indirect challenges have a low sensitivity, the treadmill exercise, but are more specific. Alternative hypertonic saline, mannitol, and further reading is recommended. If the exercise challenge is negative or a treadmill is not available, then you can do a direct challenge, and the most commonly used method is methacholine, very sensitive but less specific. And I would like to end this talk with one MCQ question. Submaximal treadmill exercise I can't read it anymore. I have to take it off. To test bronchial hyperreactivity should be performed according to a standard protocol. This does not include the following settings, so please mark the single wrong answer. The exercise level should be adjusted to reach 80 to 90% of maximal heart rate. The level of humidity in the lung function lab should be kept above 60%. The room temperature should be kept below 25 degrees Celsius. D, the treadmill speed should be kept between 5 and 7 kilometers per hour. The slope of the treadmill should usually be set to about 10%. So which of the answers do you think is wrong? And you can vote now. Yes, very good. So this is the standard protocol for the treadmill exercise. The humidity should be low because otherwise the pathophysiology, or what happens physiologically in the voluntary hyperpnea during the exercise is the loss of water from the mucosa, stimulating the inflammatory response, and the bronchoconstriction will work less well if you have a very humid environment. So level of humidity should be rather dry, below 60%. Okay, and I think we are now ready for questions.
Well, thank you, Monica and Nicolas. There are a lot of questions, so let's try to answer them all. Maybe a first question for you, Monica, because some people ask about that. If you look at
Mariel, I don't hear you anymore.
Predicted value and from the baseline value, and which one is recommended?
Actually, I missed your question. Can you repeat that? You were gone from the audio.
Okay, I'm sorry. So the question is, if you look at bronchodilator reversibility, should you calculate that from the predictive value of FEV1 or from the baseline value, which of course makes a difference?
Yes, you should calculate that from the absolute value, and then yeah, let's say you have 1 liter pre-bronchodilator test of FEV1 and then 1.2 liters FEV1 after the bronchodilator test, which that gives you a response of 20%.
Okay, thank you. And Nicolas, there's a question about this total resistance versus effective resistance, and you said you prefer the effective resistance. Can you comment on that? Why is that? And a second question, if a specific airway resistance is extrapolated from this effective resistance?
Okay, can I just give you the, can I put my slide on, or can I do this?
Maybe?
Oh no, it's deactivated. Okay, I cannot show the slide.
We
but
can put the slide back on if you would. You like?
No, that's fine. That's fine. That's fine. You have seen the SR, the effective resistance. So that's kind of a mean of the curve. So it's an integral of the curve, and it will not be so much dependent of every you know, variability in each curve. So it's more consistent if you do 3 curves. The mean of all the curves will be more repeatable. If you took the total resistance, which is kind of the highest point that your computer that puts the algorithm, if it takes the highest and the lowest point, it will be much more sensitive, but from measure to measure, it will be much more variable. So we prefer the effective resistance to which is a mean, and that you can repeat. And if you compare one, you know, what the child has done before reversibility, before bronchodilator, and after, you will better see the change. Or if you see the child coming 3 weeks later, you will better see a change. The RF, which is not the specific resistance, is basically the specific resistance divided by the FRC. And we don't use so much the RF or the RTOT because this is very much variable or dependent on the volume. I explain you this. If you have a child which is hyperinflated, which has an asthma, then if you measure the RTOT, you know, not the specific, but the R without the little s before, the RTOT or the RF, you will have kind of a false good value because the child is hyperinflated, and because of the hyperinflation has dilated airways and so the specific resistance is kind of adjusted for this. This is what you measure directly, and it does not take into account or it kind of adjusts it for this child for the lung volume. So that's why we prefer the specific resistance, and from the specific resistance we prefer the effective specific resistance.
Well,
I hope this answers it.
Yeah, you're very clear in explaining difficult topics. There are quite some questions about bronchodilator reversibility. So maybe for Monica, do you see a role for FEV 0.5 in the younger children? And the second question, is there a role for ipratropium in bronchodilator reversibility testing?
Yes, there is a role for FEV 0.5, although normal values are less well established than for FEV1, or the there are less data for that. But of course, in young children, FEV1 often doesn't work because it's the expiration is just too short, and then we look at FEV 0.5 or FEV 0.75. And the second question was
the ipratropium.
Ipratropium, yes, well, there are some children who do either not tolerate salbutamol, so you want to assess a bronchodilator response with ipratropium, or you have a specific question, then of course you can use ipratropium for the bronchodilator test. This is also less well established, but you definitely have to wait longer because the pharmacokinetics for the ipratropium are slower than salbutamol. So it is recommended to repeat the lung function about 30 minutes after the inhalation.
Okay. And then a question about several questions about bronchoprovocation testing. The first one is if the capnic hypopnea test is that more sensitive than conventional exercise testing?
There are very few data, as far as I know, to directly compare these two. From the pathophysiological point of view, they shouldn't be very different because it's the same mechanism. The problem with the eucapnic hyperventilation is that the equipment is not commercially available anymore, so it really cannot be a widespread standard. Unfortunately, it's a very elegant way to test bronchial hyperreactivity.
Okay, and a question for Nicolas. If you perform lung function testing, what do you ask your patients with medication? Do they have to stop inhaled corticosteroids? Do they have to stop LABA? And for how long should they stop that?
There are some guidelines on it. I think it's a good question. It really depends on also the patient group that you're following. In general, if you have a first patient that comes for an examination to your clinic where it's a question about asthma or whatever, then you would usually say that they have to withdraw the long-acting beta-2 agonists for maybe 2 days and the short-acting on the day of the examination. If you have patients that you monitor serially, like CF patient, basically it's not so important if they have inhaled on the day of on the test or not. The important thing is that they always do the same, and if possible they always come a little bit the same time so that you really can compare the values. So for instance, a severe CF patient, you would not be very happy to say don't inhale in the morning before coming to lung function testing, because they can be very bad and they really need the inhalation. So this would be the general rules I think we could apply.
Yeah, thanks. Then we did talk a little bit about the role of spirometry in upper airway problems like vocal cord problems. Can you comment on that? I think I was lost. Did you hear the question?
So the comment on the role of spirometry in upper airway problems, in dynamic problems like ELO, induced laryngeal obstruction like vocal cord dysfunction. Yes, of course, if you have, you need to find the moment basically where the child has a problem, because if you do a spirometry in the child where the child has not the problem at the moment, is very calm, then you will not see the inspiratory increase of the resistance. So typically you will see such a curve and have a use of the spirometry when you have done exercise challenge in the end of the exercise, or during, just when the child starts doing these strange sounds or has these problems of breathing. If you then do the spirometry, then you might see the inspiratory resistance. Yes.
Some questions on bronchial provocation testing. Monica, do you think if a patient inhales to total lung capacity during a metacholine test, can this inhibit the response to metacholine and give a false negative result?
This has been described that if you make a deep inhalation and hold the total lung capacity for very long, that this could have a bronchodilator, induce a bronchodilation, and then this might lead to a false negative result. But I think it's a very rare thing.
Okay.
The message is that if you do the spirometry, you take a deep breath in and don't hold it for long, and then just do the exhalation.
Okay, thanks. And do you have any data about normative values for PD20 and PC20? And second, which dosimeter do you recommend?
There are some data in the most recent bronchial challenge document from the ERS, which is in the literature list. And I've also put some papers which compare the different bronchial challenge methods and give you some numbers. A recommendation for a dosimeter is we cannot give here. I think the commercial devices, most of them have the option, and you should ask for validation and then try it.
Yeah. And then another question on exercise testing. If your FEV1 stays stable after 10 minutes of exercise, till what time do you repeat this spirometry?
It's a very, very good question. I can see it here. I've only described the short exercise protocol, which is applicable in clinical practice for routine measurement. If you do a full exercise protocol, you should repeat your measurement after 20 and 40 minutes. That's correct, because the response may increase over time.
Yeah.
This is just an important comment that maybe it's an important comment that you do. It also, it's the same for the metacholine challenge. How many steps will you use? You just need to find something that's suitable for the clinical practice of the everyday practice. You cannot do the whole protocols that last 3/4 of an hour. So it's always a compromise.
And then is there a role for FEF 2575 during bronchial provocation test, or maybe also during spirometry? What's your opinion, both of you?
Well, there are no reference data to use that, and the problem with the flows is that they are much more variable than the volumes, and that's why one has sort of agreed to use the FEV1, which is a robust measurement, and the other parameter, which is really very useful, especially in pediatrics, where you might have problems with the repeat spirometry, is the specific airway resistance, and this tends to be a very robust clinical measurement.
Like you can use halving of the specific resistance as a good measurement of a bronchodilator response, right?
Mm-hmm. Maybe a last question, not sure if I get this. If there can be false and positive or negative results of spirometry, for example, if you have a sore throat?
Yes, well, of course, then you might have a bad spirometry just because the child, because of the pain, will not do the complete forced maneuver. There have been studies looking at infection, and of course, an acute respiratory infection will change your values of spirometry. You can say if the infection has been several weeks ago, up to 6 weeks, then they will not have no influence. That's a little bit the cutoff. We can say if in the 6 last weeks you had no infection, that's sure. But you know, in the winter, all children have infections more than every 6 weeks.
Oh, and maybe a last question. We avoided to talk about COVID till now, which is really very good. But is there, with the COVID pandemic, do you think there's a role for home spirometry? For example, we gave our CF patients a home spirometry during this.
Yes. I think there's been a very nice webinar held on COVID and cystic fibrosis, where Nick Simmons has showed their program at the Brompton Hospital, where they try to do more monitoring at home with home spirometry, with devices that measure the movements at home, with devices and well, just the weight and all those things. So yes, of course, I think in this area, home monitoring is of use for some group of patients if you can have a good system of telemetry and telemedicine. Yes. Yeah.
I still think it's important that the lung function technicians are involved there. We now have a sort of a web consultation with the lung function technician guiding the children to do the home spirometry. And I think that really improves the values you get from home spirometry. Well, I think we have to close this session. Thank you both for a very clear and nice presentation, and thank to all the participants for the many questions, and well, maybe the questions that are left in the chat we can answer later.